Hello, everybody. I'm Dr. Sarita Rao from Apollo Hospital, Indore. And today, as we speak, the story of angioplasty has actually evolved a lot. Way back from the time when Dr. Andreas Gruenzig did the first angioplasty in September 1977, where he did a balloon angioplasty. And today, in the era where we've had bare metal stents, we've had drug-eluting stents, and now to the DCBs. So when we talk about balloon angioplasty, where we started, there were a lot of problems because we had abrupt vessel closures sometimes because of the dissections. And to circumvent that problem came the stents. So the stents were considered to be a metallic scaffold which would hold the vessel open, which would prevent all the abrupt closures for which we had to come back in the middle of the night. But then the bare metal stents didn't do very well because of the restenosis. So we invented on that, and they put in drug into that, which was anti-restenotic, anti-proliferative. So came the era of drug-eluting stents, and that worked for quite some time. It became much better. But then these very patients with drug-eluting stents started coming back with restenosis. And as we intervention cardiologists got more aggressive and we got more ambitious, we started dealing with very complex lesions requiring multiple stents. And so the incidence of patients coming back with complications, with problems, again started going up. And that led to the invention of the drug-coated balloons, or the drug-eluting balloons as we know them. So what changed? What changed was that when we had the drug-eluting stents, our problems were multiple. One was restenosis. The second problem we had was these patients had to be on lifelong antiplatelet therapy, which was a problem because many a time they were high bleeding risk patients. And there are adverse effects of drugs, as we know. And then, of course, many patients had complex lesions. So how many stents are you going to put in there? And you would have bifurcation, so the metal load would be high. And we're doing complex left main, and the metal load is getting higher and higher. So DCPs actually came in to deal with all of these problems. So the idea of the DCB is to go in there with the balloon, deliver the anti-restenotic drug into the vessel wall, and then come out and leave nothing behind. So what are the benefits we get when we use a DCB? Our benefits are multiple. One is that the metal load is zero. You've actually left nothing behind except the drug. The second thing is that you can actually do complex lesions and reduce the metal burden. The third thing is that you don't need prolonged dual antiplatelet therapy. So for HBR patients, it's a boon. The fourth thing is that when you have long lesions, how many stents are you going to put? So long lesions, diffuse disease, small vessel disease, instant restenosis where the patient already has one layer of stent, or sometimes they come in with 2 layers of stent. Are you actually willing to put in another layer of stent inside? So in all of these scenarios, DCBs have actually paved the way for a newer form of treatment. So when we use the DCBs, we actually have a positive remodeling. There's a late lumen enlargement, and the vessel maintains its vasomotor function, and your antiplatelet therapy duration goes down. So all of these benefits have actually given DCBs a very important place in all of our cath labs. So typically when I say, today I want to do an angioplasty, and the patient has either ISR, diffuse disease, small disease, branch vessel disease, bifurcation, osteal disease, I would typically think of using DCBs. It's not that we've done away with the stents. The stents are still very useful where they're required. But today we look at a more hybrid or a blended approach. So if we look at a therapy in which stents have their own places and the DCBs have their own places, and many a time we use a combination of the two.